Good morning, everyone, and thank you so much. And thank you for the nice introduction, and also for the invitation here to be in Malaysia and this very successful congress and the amazing university and campus. You guys, you should be proud of the campus, the achievement. Today I had a tour and the medical science life. It's really, it's giving me vibe having students and researchers. It's really with this positive, let's say, feeling to go back into the schools, being on the sleepless night, and I think because of jet lag, also I had some sleepless night, so I'm getting back into this. So thank you so much. Okay, you will. So yeah, next slide, please. So the work that I'm gonna, it's a policy research. This is, and just kind of put disclaimer. I really believe in public health, that we need to work more and more at the level of policies, because this is actually where we have the highest impact. And this is a policy research that we've done as Qatar Cancer Society is a member of the. We work in the All Can International. It's an organization level, international organization that work on setting efficiency in cancer care, and it's a very important topic. And actually, the outcome of the work of the efficiency metrics is actually being now adopted by the European Cancer Plan at the level of European Union, and it will be adapted also, hopefully, internationally, on the whole concept of we really need to think of efficiency metrics in cancer care. So building efficiency in cancer care. So the lens that it's the principle that formed the lens and let's say the way that we are looking into this project it's based on three principles. First, putting the patient first. So we look at the cancer care, the efficiency from the perspective of the patient, people living with the disease, not from the level of the finance, Minister of Finance. So that's a very, because we had a lot of discussion, efficiency, do we need to look at it from health economic, from the finance? No, we said our first guiding in the process is actually the patient perspective. The other aspect is we want to adapt system-wide solution. So really to target efficiency, you cannot just look at the piece here, piece there. We need to look at the whole continuum of cancer care and work at the system-wide solution. And the third principle is we want to do, no one can work alone on this. We need to approach multi-stakeholder approach. So that's why we all got, in the whole policy research, you will see that it's always approaching multi-stakeholders, everyone involved in the continuum of care. Next slide, please. So we had you are welcome to go. There are a couple of documents. It's accessible free on the website. The policies, we start first with defining what's efficiency, what are the importance, and then we start working on the efficiency metrics. So we have those four dimensions. The fourth dimension is we need to empower our partners with the people. So it's this is, as I mentioned, this is multi-stakeholder approach. The other aspect is we need to support healthcare professionals. One of the things in efficiency, we found that how the healthcare professional will adapt efficiency without being supported, because they need to be incentivized for being efficient and for adapting to efficiency metrics. And also we need to implement how we can be efficient without data-driven systems and health systems. So, we need to invest with all of that data system. When we work together, we invest in healthcare professional, we support them, then we focus on the data system, then we can invest in efficiency technology. We cannot, jump in to implement efficient technology without building the foundation that I mentioned, the dimension. Next, please. So we have we need to do more of adaptive. One of the major things is we need to have an adaptive learning system, and this is very important with the efficiency and the fast pace of changing the technology. The system need to be adaptive and learning to implement more and more healthcare system to have equitable access. So the way let's say the implementation, how we can scale up, we need to reduce diagnostic delays. This is, and use better pathways, better and risk reduction, error detection, and so on. Other thing is to move closer to home. So the care need to be, so we need to build the capacity for clinical nurse specialists, for the follow-up, for the primary care, where the patient get their tertiary care. They need to go back to their home, care closer to home, to invest in a healthcare professional. And the third dimension, we need to support people living with cancer beyond the active treatment, so the survivorship care. This is actually, we all know that cancers there are a high recurrence rate. And if you don't put good survivorship care for cancer patient, they can get recurrence, and recurrence get missed, and they go into advanced stages. So that will impact the efficiency of the care also. So that's why we need to focus on the survivorship care. We need to tailor this. This is focusing also on the special need for children with cancer. That has this specific dimension in the policy, that they have special needs, and also their parents, their family. So they focus on that, because most of the time the oncology research focusing on adult. A lot of research is not focused. You kind of get the child. That's why WHO put the WHO Childhood Cancer Initiative kind of left behind. So we put that as a focus point in the implementation. We need care navigation, and I think you guys here at National Cancer Society of Malaysia, I really admire the program in the patient navigation, and I think this is a very important program. Can focus more and more on it. Developing solution to maximize local resources. So we really need to evaluate all technology and solution, and capitalize investment in the one efficient one, and the one not efficient, we need to de-invest from it. And this is very important point. We really, when we evaluate health technology assessment or any sort of, that's something very important, efficiency. If it doesn't work, don't invest in it anymore. Invest in the more efficient solution. And that decision need a decision maker and bravery. Sometimes because people get used to it and they cannot de-invest from it. And using data and online platform precision medicine. And I think having Cancer Research Malaysia here with us is with the whole, pushing forward on precision medicine and so on, and solution we really need to implement in a data format. So we get this information, the data from the sharing data from the patient, and move forward with precision medicine solution. Next slide, please. So this, we can go to the next slide. So this is kind of how the reports, the journey. So we had I don't know, I can't recall, almost 3,000 articles has been reviewed on looking into efficiency in cancer care. We had a lot of gray documents, so we did not look until the published and let's say peer-reviewed. We looked at a lot, because the topic of efficiency, we found out that actually most of the robust, well-formed document is the gray document, the white document, the one not peer-reviewed that they go into this discussion. So I recommend whenever you guys are moving into policy research, don't miss searching into gray document. You will miss a lot of information and input if you just only focus on peer-reviewed, because unfortunately, till now, most of the peer-reviewed publication, the work on policy, you don't see it in the peer-reviewed, you see it more in the gray document or white document. Meaning the not peer-reviewed, the one not published into, I don't know why they call it gray or white, I have no idea, but they are not peer-reviewed, let's call it that way. And we did also interviews with stakeholders, multi-stakeholders, and we came up with 13 metric categories for cancer care efficiency, and I'm going to walk you through it. Timelines of care, the quality of care, therapeutic alliance, the multidisciplinary team involvement, the continuity of care, the palliative and end-of-life care. Actually, it's a lot of evidence and efficiency of cancer care focusing on the palliative care, end-of-life care. They feel that there are a lot of, there is a room for improving efficiency in that aspect. Psychological oncology, psychosocial oncology, the information support shared decision making, and the patient experience and patient involvement in care. because, as I told you at the beginning, patient views are the main principle that we focus on developing the policies. The survivorship, the financial toxicity, and that's the aspect, is actually access mainly. You don't have the bell today? I used the bell. I like the bell more. The patient-reported outcome, and I don't know about here in Malaysia, but in Qatar we still, and most of the region, we found out not so much in our region there is a value for, tracking for patient-reported outcome, patient-reported experience. It's not that much has been implemented in a systematic way. The oncology world, unfortunately, if you look in other part of the world, let's say North America or Europe, and I think we should lead in this, because our culture is we really kind of chatty, share our feeling. So I think we really need to be leading on the patient-reported outcome, social environment and innovation. Next. So those are, the cancer efficiency metric categories. We looked into the published metrics. So we had like almost 140, 137 metrics, but we need to identify. We cross-reference and we kind of look which one is more mentioned across the publication on different input from the stakeholder interviews. And we felt we look for core metrics that they are routinely collected. So we cannot just recommend metrics that they are not usually routinely collected, because we based all of our decision on data, so it's not been looked into it routinely. Then why we put it as a core metrics? And also that it can match all type of cancer, because we are looking at all type of cancer, not specific type of cancer, and that always coincide with patient interest. So the metrics that matter to the patient. So that's the kind of how we looked into the 137 metrics, and we come up with the core metrics. Time to diagnosis, percentage of cancer diagnosed through emergency presentation. The primary care interval, which is the interval from the first time patient presented in primary care with symptoms indicate suspected cancer, all the way to the time that they actually being referred to the tertiary center. So that's the primary care interval. And that's, by the way, this is where we all need to invest. A lot of, on average, primary care, I'm gonna digest here, because this is something we will focus on Qatar Cancer Society. Primary care on average, physician, I don't know, in Qatar, all over the world, maybe they will see 1,000 per year, 1,000, 1,500 patients. It depends where they are. They may see a total of 12, 13 type of cancer patient. And from that 12, maybe 3 of them breast cancer or something like that. So imagine, so we need to invest with the primary care to always boost their knowledge, so that that primary care interval shorten. We need to shorten that period. So they get, from the moment they get suspected, they get referred. Either through education, through advancement of the technology, through, definitely, early detection and so on, but also when we talk early detection, screening, and so there is all the early diagnosis. So we cannot just focus on screening, because we cannot, at the end of the day, come up with screening tools for 156 type of cancer that's being recorded in the WHO, IR. You can't, but you can invest in the early diagnosis and shorten primary care interval. The other metrics, time from tissue diagnosis to treatment, and percentage of patients documented of having seen a clinical nurse specialist. And this is very important, because maybe every part of the world has different terminology. Clinical nurse specialist, mainly the care coordinator, the nurse that coordinates the care, because as we are all aware, maximum time of the healthcare professional, medical oncologist, surgical oncologist, what can be? 10, 15, 20 minutes. But who's going to continue the care? The nurse specialist or the nurse coordinator for the cancer pathway. So they need to be seen. The percentage of patients who received chemotherapy in the last 14 days of life, also for the palliative care. The patient experience, patient involvement, decision making. And this is very important also as we are focusing on the patient needs. Next, please. So this is how we are envisioning the implementation of the plan, the implementation plan for the metrics. So it's going to be, the cancer efficiency metrics map, the phase 1, we already done with that. the phase 2, the efficiency metric implementation guide. We are working on it. It will be launched in the World Cancer Congress in Switzerland, Geneva, and the version 1, and co-create national project, the co-pilot this playbook to national project. That will be done next year. Next slide, please. So the efficiency care map, if we can go to the next slide, it will make more sense. So what we did, and it's available on the website, we looked at the members, organizations in the OCAN and also other countries that they are interested to take part. And we did a heat map. We reviewed we developed a survey in the research and evidence group in OCAN. And that survey, digital survey, is distributed in addition to interviews with the organization. Mainly, the main focus was reviewing the national cancer care policies. Is it implementing efficiency metrics? Is there initiative that focusing on the efficiency for cancer care? And hopefully after this we'll have over Malaysia, and we have from the areas Japan and Korea. But we definitely we can have focus more on efficiency. Next slide, please. And this is how it looks like. This is like example point. The cancer policies. We reviewed different chapters. So, do they have cancer control plan? Do they have implementing evidence-based primary prevention, secondary prevention, tertiary prevention guideline? Do they have access to prompt, well-coordinated, multidisciplinary treatment? And if you go to the next slide, and then we can compare. And this is, by the way, not the purpose is to compare who's the better or who's the best. This is just for understanding of, by the way, we found throughout the study that sometimes the National Cancer Plan does not represent, the country may be doing it, but it's not written in the policy document or the cancer control document. And that's kind of give us feedback that we need to connect those initiatives to the National Cancer Plan, so to have emphasis and value behind it and push from the legislation. Next slide, please. And this is it's a kind of comprehensive overview how we're gonna the implementation guide project. We first looked at the core efficiency metric groups, and we took fitness of use consideration. I'm not going to go through it. This is well-known implementation process, fitness of use. And then we started decision-making context fitness for purpose. So we combine the fitness for use, fitness for purpose, and we start the implementation strategy. We synthesize knowledge, then adapt, then we need to implementation determinant. And this is very important. We need to know the precondition, assess the health system, and what are the determinant or the factors that could play a factor in the implementation. And tailored intervention, monitoring use. And so as I told you, Playbook 1 will be coming in September, and then we'll do international validation, we'll go to Playbook 2. Next one. I'm going to focus, the tool will come up, the implementation guide, come with guidance and recommendation and health system approach. But what's nice about this tool, it's non-linear. You can pick what you want, and you can have the entry point that you want in that tool. You don't need to go through the whole cycle. You can choose what you want based on the need, the context of the country. And it's a living tool. You can just, it's a guideline of implementation. You can manage it, change it the way that you want. Next slide, please. This is kind of the user guide for the implementation guide, the why, the what, and the how. Next slide, please. The why we need to think where we're going to adapt. Are we going to adapt it at the micro level, at the process of care decision making, because that will make it freedom for different organizations to work on it. Small organization, big organization, do they need to work at the organization level, network level, meso level, or they need to work at the macro level, the policy, the system decision making? That's how it kind of give the freedom of adaptability to be adaptable by different size of organization. Next slide, please. And this is just look at the metrics in different efficiency metrics in different practices, different part of the world. And again, this is not to kind of say who's better. This is just more for understanding and tell you part of the cancer policies where are those metrics is being implemented in cancer control policy. And this is then we decided this is to make it a non-linear tool. we need to group those efficiency metrics. So people, they have those different entry point, which is, we came up timelines of care, coordination of care, and patient centeredness. As I mentioned, patient goes. If you look, you can look at what are the key efficiency metrics attached to entry point of efficiency, those clusters. Next slide, please. And for each, let's say, clusters of efficiency metrics, the entry point. So timelines of care, what's the entry point at the level of the system? It's the data infrastructure. So that's kind of the entry point that can, time's up, yes, now I get the bell. Workforce coordination of care, the workforce and organization. So we need to focus on from the care nurse specialist, care navigation, the MDT, and the patient centeredness, patient perspective are the patient reported outcome, patient reported experience. And I'm not talking about satisfaction. I have to put this disclaimer. A lot of entity, they do patient satisfaction survey. Doesn't, I mean, it's good, don't get me wrong, it's good. But it's not different than any satisfaction survey you're doing at the airport. When you come here, do you like the airport? Yes, no, smiley face, that's it. We need to think of really experience outcome and outcome measurement. You know, this is kind of the path you go through. You select a goal, you want to work at the care coordination, you want to work at the patient centeredness, you want to work on the data, then you assess the health system preparedness for this. And the important one, you need to identify key contextual factors that determine the level of health system for the success or the barrier. And then you come up, you get stakeholder involved, the key recommendation. Next slide, please, to show you. So this is a very important exercise that we need to do at the health system before we start anything. We'll look at it's used ICON framework, and my colleague here from WHO on monitoring evaluation, you know, it's a very, the ICON, you know, the integration of care, the outcome, the network framework. And we can go to the next slide because time's up. Next one, let's just show you and then we'll come up with the recommendation. At which level you want to have the recommendation? Go back, sorry. At organization level or for community patient advocate. So this is kind of going through the exercise of implementation guide to come up with this recommendation. Next slide, please. And just an example, you know, this is what has been done by the member organization already in the OCAN. The data level, the cancer performance indicator dashboard in the UK, workforce, Canada, nurse navigators. I think we can add Malaysia definitely here, India. I mean, you know, the leading in the patient navigation, Argentina care navigation also they're breaking. The patient reported experience measures. We need to do more and more of this. So actually, in the region, we need to really work on this. You can go to the next slide. So just call for action. You know, I can summarize. Really, we need to really focus on adaptive learning health system. Seriously, this is without looking at the patient, at the health system from patient perspective, we will not be moving forward. And efficiency in cancer care. Why it's I'm calling for this action, focusing on policy, because when we get more efficient, more equity, more high quality access, we will have more funding for a high value project. All of us here, maybe as we are here in the research track, we may complain we don't have enough funding for research. Guess what? Why we are not having enough funding for research? Because the care is provided in an inefficient way. The funding allocated for health is being consumed in inefficient practices and technology that taking the money away from the research investment. And thank you so much. Only 5 minutes, I appreciate it.